Good afternoon, ladies and gentlemen. I would like to thank AOS and Dr. Swati for having me here. Today I am going to speak on decoding the color coding on OCT. As we all know, structural damage precedes functional loss, and even in mild glaucoma, approximately 50% of the ganglion cells are already lost before apparent on visual fields. And all we know that visual fields are not always reliable and reproducible. So OCT is the important tool to diagnose and to monitor progression in perimetric glaucoma. There are three standard scanning protocols that are used for glaucoma diagnosis: circumperipapillary retinal nerve fiber layer scan, optic nerve head scan, and macular scan. This is OptoView scan where we get RNFL index values, ONH, GCC, TSNIT map, symmetry analysis, RFNL thickness map, and GCC map. So before reading OCT, don't get fooled by red and green areas. False red and false green results are fairly common due to artifacts. So what is red disease? A diagnosis of glaucoma is made based on mistaken identification of an area as abnormal. These commonly occur in patients who are not represented on normative database, and RFNL thickness falls outside the normal range and depicted in red color, which can occur in non-glaucomatous eyes too, and in extreme refractive states, especially in high myopia. And what is green disease? A glaucoma diagnosis is missed as OCT appears normal. Here on this fundus photograph, you can see there is a wedge defect. There is a wedge defect, but the OCT is normal because the instrument averages the thickness in a particular sector. Again, on this fundus photo, you can see the wedge defect, but the OCT is green color because the focal change is masked by the global parameters. Look for the artifacts and anatomical variations. These may occur in 1/3 of the cases. Scan quality affects the OCT performance. If the signal strength is poor, you have to figure out the cause. It might be because of cataract, any media opacity, corneal edema, vitreous floater, or dry eye. And also look for the technical errors, might be because of discentration, blinks, and eye movements. Pupil dilatation does not affect the signal strength, RNFL measurement, or reproducibility in normal eyes. Minimum pupil diameter requirement is 2 mm for OCT measurements. On serous OCT, signal strength should be 6 or more than 6, and on OptoView, it should be 40 or more than 40. This is an OptoView scan where you can see in the left eye there is FLV and GLV loss, and on this GCC map you see the red area here. But in the same patient at the same time when we repeated the scan, everything came to normal, and this was because of this blinking artifact. Again, you see here the red black dot here, and sometimes during the acquisition of the scan, patient blinks the eye and this type of black horizontal line can be seen. So in these types of patients, machine is missing the data, so it can be flagged as red. So this is because of vitreous floater and blinking artifact, and you should repeat the scan and look for these type of artifacts. Again, there can be a centration artifact. If you see the breakage in the blood vessels, this is because of motion artifact, and these black horizontal lines, these are all blinking artifacts. Scan alignment is very important. A well-focused scan where the entire RFNL is in the scan area. And the next is the defocus scan. Here this is the serous OCT where this black area is the artifact, and on this, when you see at this RNFL thickness map, the thickness is going down to 0, which is not possible. So when we looked at this horizontal and vertical tomograms, you see that this is not well focused. This is defocused. So this is flagged as red. So in these cases, we should repeat the scan again. Again, this is OptoView. In the left eye is the registration artifact. There are other factors that can affect the OCT parameters like age, optic nerve head variation like tilted, small, large disc, axial length, high refractive error, and blood vessel position. All OCT normative data is age related. This is serous OCT scan of a less than 18 years of patient where the normative data is not available for comparison. So date of birth is very important when you take the scan. Optic disc size, larger discs have thicker RNFL measurements. Since the 3.4 mm measurement circle is fixed, so when the RNFL goes out of the optic nerve, it is thicker, and when it fans out, it becomes thinner. So in the large disc, it measures that thicker RNFL. So larger disc, they must suffer more damage before resisting as abnormal on OCT, and they have lower sensitivity for early glaucoma detection. And mild glaucoma is most easily detected in patients with small optic nerve head, but these discs are associated with false positive results too. Axial length, the longer the eye, thinner the mean RNFL. With every 1 mm increase in axial length, 2.2 micron meter decrease in RNFL thickness occurs. So there are high risk of OCT false positive results. Look at this example. Here the disc is okay, but and the RNFL thickness is quite good, but the RNFL bundles are converging temporally here. RNFL bundles are converging temporally instead of going like this. So the machine is measuring this area as a deviation, which is an anatomical variation, not a glaucomatous condition. So this is known as the lateral RNFL shift, which is seen in high myopic patients. In cases of large peripapillary atrophy with posterior styphyloma, erroneous results can occur due to inability of the measurement circle to stretch beyond this large peripapillary area, and it can cause the segmentation error and cause the red disease. Blood vessel positions. In the RNFL bundles fall on major blood vessels, so variation in the blood vessel position can cause variation in RNFL profiles. So if you see at this example, this this area, do you think this is a real defect? When you, and also at this RNFL thickness map, this double hump pattern is lost and the RNFL thickness is going down. When you look at this fundus picture, two RNFL bundles are going into one optic nerve and instead of one. So this is known as split RNFL bundle. Here you can see this black area where the machine is missing the data, and you can see this floor effect, which is again not possible. So we asked the patient to move the eye and again repeated the scan, and everything came to normal. This was because of this V's ring. Here again you can see the lot of red areas and the elevations on instead of cupping on this vertical and horizontal tomogram. And visual field effects are also there. When we look at the fundus photo, you can see the hyper-reflective bodies. This is optic nerve head drusen. These patients are very difficult to diagnose. And another example, here you can see the hyper-reflectivity and the thickness is very high. And the shadowing effect, this is because of this medullary nerve fiber layer, which can cause false green disease. Again, sometimes during OCT some OCT part is blocked by the iris in cases of poor pupil dilatation. So it can cause this red disease, this and cause the incomplete segmentation artifact. So these type of patients, scan should be repeated after dilatation of the pupil. There are other ocular anomalies like ERM, vitreoretinal tractions, V's ring, peripapillary retinoschisis, and uveitis that can cause artifactual increase in RFNL thickness and cause the false green disease. Look at this example here. The cupping is there, but in the left eye, the thickness is going 137, and here this is going high in the sky, which is very high. This is because of this. When we looked at this scan, macular scan, because of this cystoid macular edema. Again, this is an example where in the right eye, if you see the lot of RNFL thinning is there, but the cup volume is 0. And the visual fields inferior quadrantopia, and when we looked at the disc photo, this is a case of post-papilledema optic atrophy. This was again a case of superior half is lost here, and inferior altitudinal defect in the right eye. But when we looked at this macular photo, the superior neurosensory retina is lost above the fovea, and this right eye fundus photo, this disc is pale. This was a case of non-arthritic ischemic neuropathy. So, and the OCT has no role in advanced glaucoma cases because of this floor effect, because the RNFL thickness rarely falls below 50 micron and almost never below 40 micron due to the assumed presence of residual glial or non-neural tissue, including blood vessels. So, in nutshell, these operator-dependent, machine-dependent, and patient-dependent factors can alter your scan, and you should look into all these things. And take-home message is that acquire a scan with proper protocol, look for artifacts and anatomical variations, pay attention to all maps on the OCT. If any discrepancy with the clinical picture, repeat the scan. Careful correlation of RNFL and GCC with clinical picture and perimetry reduces the erroneous results. Thank you.